pharmacology second lecture. So topics we will cover is the route of drug administration. In that there are two routes, that is one is local or tropical route and another is systemic. In systemic there are two types, enteral, parenteral. So what are the factors governing the route of choice? There are six factors which govern the route. First is properties of drug. So the properties, physical and chemical properties of drug, that is whether the drug is solid, liquid, gas, pH. What is the pH of the drug and soluble or not soluble? Next, the site of action, where the drug is to be given. What is the action where the drug should act? One is easily approachable and one is not easily non-approachable. The easily approachable site is the localized site. Non-approachable sites, some sites are inside our body. Deeply we cannot approach them. So we should give drugs in another place so it circulates and goes through it. So it is called a generalized site. Next, third factor governing the route of choice is first pass metabolism. So first pass metabolism. See any drug which we give orally, it passes through GIT and then through anal and then it goes to circulation to liver. There is inferior vena cava, it goes to that, circulates inside the body. So drug passing to the GIT, it is known as first pass metabolism because their drug is utilized and the drug which goes to and the amount of drug remaining which goes to circulation is called bioavailability of the drug. So this is known as first pass metabolism. If a drug has high first pass metabolism, then it will be utilized in GLP and its bioavailability will be less. So the drug is not preferred via oral route. We should choose alternative route. Next, routine treatment, and another factor governing route of choice is routine treatment or emergency. In what conditions we are giving the drug. Next is patient condition. Is the patient unconscious or severe vomiting? Some patients vomit when they are undergoing vomiting, and if we give drug, they vomit it also. And next, the actually speed with which the response is desired. How much fast the response is desired. Next is rules of drug administration. There are two rules, local route, systemic route. What does local means? By the name we can say that local, that means aim is to see that drug remain confined to a limited area. Systemic means aim to see that drug reaches the blood and distributed widely in the body. It is distributed in the body. Local, it remains same place. Systemic route, it is distributed. At first, local. Site of action is same as the site of administration, means where the drug is administration, action is also going on there. In local also there are two types. One is we give surfacely and another drug we give deep tissues. So surface we call as topical. Example skin. On skin we apply ointment, powder, lotion and various mucous membranes. Mouth washes, gargles also. We give buccal and drops, ointment, antacids, vaginal placeholders and parenteral enema in chronic constipation. Parenteral drugs, there are two types. One is in parenteral enema, we give parenteral enema and another type of drug which is systemic. Parenteral enema comes under local. We give this in chronic constipation. Next, deep tissues. Intra-articular method. Inside the tissues we give. Example, hydrocortisone. Intra-arterial. Inside the artery we give hydrocortisone. Angiography intrathecal, it is given inferior to subarachnoid space. An example, baclofen, which is given in disease called ALS. Next is systemic route. Systemic route action of drug is going to be seen after the drug reaches the systemic circulation. That is, the drug is distributed. So systemic circulation, it is of two types, enteral, parenteral. Enteral, the drug passes to GIT, but in parenteral it bypasses that, it doesn't pass through GIT. Enteral, there are two types, per orum, per lingual, sublingual, per rectum. Per orum means behave orally, and per lingual, sublingual behave under the tongue, and per rectum behave rectum. So from rectum to oral it passes. Next, per orum, it is convenient, cheapest and most commonly. We most commonly take tablets from our mouth. Sublingual, the tablet is kept under the tongue. As in angina, nitrates are kept under the tongue, sublingually. And they also bypass first part metabolism, as it is absorbed in the tongue. It doesn't pass through. The tablet doesn't have to go through GIT. So this bypasses FPM. Next, per rectum, we give in rectum. It also bypasses first pass metabolism, that is 50% it bypasses. In per rectum, there are two types, diazepam and enema. Enema we give in constipation, diazepam we give in febrile seizure. Enema is locally we give it, and diazepam it is systemic route. And antacids also, they are local routes, they are not systemic. Next, parenteral. See, parenteral, this doesn't pass through GIT. Example, intravenous, intramuscular. So we can see that they are directly given in venous, so it is fastest onset. It is fastest onset of action, and it is preferred route in emergency and unconscious patient. And massive fluid infusion is required so that it gets circulated. And 100% bioavailability. Like, we told you what is bioavailability. It is 100% bioavailability. Next, intramuscular route, it is also used during emergency. Example are anaphylaxis. Bioavailability is close to 95 to 100%. Close to 100, but it is never 100. I repeat, it is close to 100, but it can be never 100. Intravenous, it is 100% bioavailability. So intramuscular antibiotics, adrenaline, these are examples. Next is parenteral continuation. Another example of parenteral is subcutaneous, that is under the skin. It is of slow absorption, not preferred in emergency. Example, insulin and vaccines such as measles, mumps, and JE, that is Japanese encephalitis, and all these we give vaccines. So they are also given subcutaneous. Heparin and low molecular weight heparin. Blood forming drugs like oprelivkin and filgrastim. These all we give subcutaneously. Next is epidural anesthesia. For prolonged surgeries, we should do more surgeries, so we give that epidural anesthesia when surgery duration is more. Next, intranasal or inhalational drugs. They are by name suggestion, they are given intranasal. Example, intranasal decongestant, and inhalation we give insulin and antibiotics. Insulin, Afrezza. I will show you what Afrezza is. Remember, these both are parenteral routes. So in parenteral we study, first was intravenous, that is 100% bioavailability. Second is intramuscular, 95 to 100% bioavailability. They both were given in emergency. Third is subcutaneous, and it is low, it is not preferred in emergency. It contains insulin, vaccines, heparin, and blood forming drugs such as oprelivkin and filgrastim. Next, epidural anesthesia when prolonged surgery, intranasal, inhalation. In inhalation, we give Afrezza. I will show you what Afrezza is. Afterwards, I will show you what Afrezza is. Next example is transdermal patch. There are patches, they are in rectangle shape. Patch means, like sticker type. Transdermal patch, which is applied on skin. Hairless skin, we apply it. Then it is absorbed. Absorption seems slowly via capillaries. Capillaries absorb that. Drug enters the circulation. That is circulation, parenteral and systematic. Example, rotigotine and rivastigmine. Rotigotine we give in Parkinson's disease, and in Alzheimer's we give rivastigmine. Next, seventh is intradermal. We give it in 10 to 15 degree angle, it is almost parallel. Intradermal BCG, for example, intradermal BCG vaccine, intradermal penicillin sensitivity test. Site of injection it is monitored. Next, rabies vaccine, intradermal rabies vaccine. So next, I say no, we give some tablets sublingually. See, there is tongue, tablet is below tongue, sublingually. I gave example of in angina, we take nitrates like this. And what I said, it bypasses the first pass metabolism. So advantage of sublingual route is onset of action is fast and it bypasses the first pass metabolism, so more bioavailability is there. Once desired action achieved, it can be spitted, but its action is achieved quickly. Disadvantages is it can cause tooth staining, tooth decay. And its example, as I said, nitrate given in angina. Next is enteral. In systemic, there were two routes, enteral, parenteral. In enteral, I gave example of per-oral, sublingual, and per-rectal. So in enteral, per-rectal, the drug is in form of bullet shaped. It is passed through rectum. In chronic constipation, when we give it, it is local, it stays there only. But in seizures, when you give it, it undergoes in circulation, that is, it is systemic. So remember, in chronic constipation, local, in seizures, systemic. Next, angle of injection. What should be the angle of injection when we give? Intramuscular, it is injected 90 degree. And subcutaneous, it is injected 45 degree. Intravenous, 25 degree. And intradermal, almost parallel, that is 10 to 15 degree. Next is what is Z-track? A type of deep intramuscular injection. Intramuscular injection, deeply when it is given. So how to give a deep intramuscular injection? These are the steps. First we should, I will explain it, wait. So first, suppose this is skin. First we should pull this skin. And then we should inject. And then we should leave the skin. Like we should leave it and we should remove the syringe. So imagine this. So it is called a Z-track because we are pulling and then leaving. Given to prevent drug efflux, the drug should not efflux and skin staining should not happen. So that's why we get drug like this. Example, iron is injected like this and antipsychotics drugs such as paliperidone, these are injected like this. So steps I already told you. Next is transdermal patch, whatever we are talking about, like these are the patches and they are of leaves. Examples of them are hyoscine, which is given in motion sickness, clonidine, alpha 2 plus, it is given in hypertension, diphenhydramine, which is also given in motion sickness, nitrates given in angina, rivastigmine in Alzheimer's, rotigotine in Parkinson's disease, salicylate in Parkinson's disease, nicotine patches, for smoking de-addiction, we give nicotine patch, and phentermine in opioid analgesia. When we give opioid, we give phentermine transdermal patch. Next is systemic. We learned enteral, parenteral. In enteral we learned per-oral, sublingual, and per-rectal. In parenteral we learned intravenous, intramuscular, subcutaneous, and then we learned inhalation and this. So now we are learning now intranasal and inhalation systemic route. So nasal. Nasal is highly potent agents can be given. Example, peptides. We can give peptides nasal, intranasally. They are highly potent agents. We can do it by self we can do it. Self-administration is possible. Rapidly it is absorbed. Example are GnRH agonist, desmopressin, calcitonin, sumatriptan. Next is inhalational. That was intranasal. It was we should give, and inhalational we should inhale it. For systemic effect, for local effect. For systemic effect, no first pass metabolism and rapid absorption. It does not undergo first pass metabolism and it is rapidly absorbed. Example, Afariza. Afariza I will show you. And next for local effect, that drug should be there only. For this, it is less systemic side effects. Systemic side effects is not seen. Example are Saba, tobramycin, Xanmerin, Saba steroids for bronchial asthma. In bronchial asthma, we use Saba and steroids inhalational way. And tobramycin for pseudomonas. In cystic fibrosis, we give tobramycin. And for influenza A and influenza B, we give Zanamivir by inhalational route. Next, this is Afariza oral inhalation. I was saying that it undergoes systemic action. It is taken like this inhalation. It is inhaled. Example, inhalational insulin. Okay, thank you. I hope you liked this lecture. If you liked it, please like, share and subscribe. And I will be uploading third lecture of pharmacology soon. I will be starting with microbiology and pathology also. Thank you.